So today I'm going to discuss something about systemic sclerosis, and we're going to continue with our Mrcp basis consultation station. So let's start. As in my previous presentations for the Mrcp consultation station, we'll start with the case scenario. So this is one of the example of the case scenario. So you're a medical doctor conducting an outpatient clinic. A 52-year-old female patient presents with a history of progressive symptoms. She complains of a Raynaud's phenomena, which she has experienced for several years, and she recently noticed skin tightening, particularly in her hands and face. She also mentions some joint pain and GI symptoms. She appears anxious and concerned about her health. So again, as I told you before, whenever you read the scenario, concentrate on the buzzwords. So here we have some buzzwords like Raynaud's phenomena, there is some skin tightening, and there is some joint pains and some GI symptoms. Okay, let's move on. So once you read the scenario, you're going to enter the room, you're going to take consent from the patient, greet the patient and the examiner, and then you start the history. So we're going to begin by introducing yourself as a medical doctor and addressing the patient by name in polite and respectful manner if the name is written there. You're going to establish rapport by showing empathy and understanding and recognize the patient anxiety and assure her that you are there to help. Then we're going to start with the chief complaints and presenting symptoms. So we're going to start by asking the patient about her main reason for the visit. For example, I understand you have been experiencing some health issues. Could you please tell me more about your symptoms? And then we encourage the patient to describe her symptoms in detail, including the onset, duration, and progression of skin changes, Raynaud's phenomena, joint pain, and GI symptoms. So the patient will volunteer whatever information she is allowed to give without any prompt. You're going to ask in detail about the skin changes because it's mentioned in the scenario. So inquire about the specific skin changes she has noticed. You're going to ask about skin thickening, tightening, any areas of discoloration or shiny appearance, and discuss any symptoms of itching or pain associated with these changes. We're going to talk a bit about Raynaud's phenomena as well. So explore her experience with Raynaud's. Ask about the color changes in her fingers or toes during cold exposure or stress, as well as any associated numbness or tingling. Explore GI symptoms by investigate her GI symptoms, including difficulty swallowing, acid reflux, abdominal discomfort, and any changes in the bowel habits. What about the joint pains? Ask about the location, onset, and nature of a joint pain. Determine if it affects her mobility or daily activities. Systemic symptoms. Inquire about any other symptom like fatigue, weight loss, or shortness of breath. And explore the past medical history, specifically any known medical conditions, any family history of autoimmune diseases, and any history of environmental exposure or potential triggers. We're going to explore a bit more, and we'll ask about the medication and allergies. So ask about her current medications, including the over-the-counter and herbal remedies, and explore any known allergies to medications or foods. Psychological impact and quality of life. Discuss the impact of our symptoms on a daily life, work, and relationship, and address any psychological or emotional aspect. Inquire about the support system. And inquire about a family history of autoimmune disease or any relevant medical condition. And finally, social and lifestyle factors. So we're going to explore the lifestyle factors like smoking, alcohol consumption, and dietary habits, which can be relevant to autoimmune disease. So once you have gone through your history, you have some idea that you are dealing with some autoimmune conditions, and most likely because of the skin tightening, patient has systemic sclerosis. Once you proceed with the examination, going to do with the general inspection first. So note any obvious facial changes, taut, shiny skin, pinched nose, microstomia, and look for any evidence of telangiectasias on the face and hands. Check the hands for sclerodactyly. Sclerodactyly is actually thickening and tightness of the skin of the fingers. Look for any digital ulcers or pitting scars. Going to proceed with the hand examination. So look for renods, white, blue, red color changes. Obviously, this one may not be evident because renods normally happens on the exposure to cold. But look for any digital ulcers, any pedicle scars or loss of digits, and observe for scalerectally and muscle wasting. Palpate the hand for any tendon friction rubs and check the temperature of the fingers. Palpate the radial pulse and check for the functionality of the hand. Ask the patient to making a fist, and this may be difficult because of the skin tightness, and evaluate the patient's grip strength. Moving on, look closely at the face. Do the inspection, note any changes in the appearance of face, shiny skin, loss of wrinkles, pinched nose, microstomia. Look for any telangiectasia on the face. Ask the patient to open the mouth as wide as possible. Measure the mouth opening if necessary, but usually it is not needed. And check the oral mucosa for any dryness or ulcers, and take a look at the teeth and gums as well. Then we will proceed to the chest examination. Listen to the lungs for any evidence of pulmonary fibrosis, and you may hear some fine and inspiratory crackles. Going to proceed a short cardiovascular examination. So examine the heart, looking for any signs of pulmonary arterial hypertension. So normally specifically look for loud P2, right ventricular heave, or a tricuspid regurgitation murmur. Check the range of motion of the joints, looking for any evidence of arthropathy, and look for any signs of muscle weakness or atrophy. Further relevant examination, we examine the abdomen for evidence of GI involvement, maybe some distension there. Check the blood pressure, particularly the postural reading. Autonomic neuropathy, well, it can be a feature of systemic sclerosis and can lead to postural hypertension. And examine other system as relevant based on the patient presentation. I'm going to thank the patient and offer assistance to help them redress if necessary. So this is briefly about the examination. So try to be systematic. Start with your general inspection, do the hand examination, face, chest, cardiovascular, musculoskeletal, and then the other relevant examinations. So what is the differential diagnosis of this patient? As we know that I already told you that most likely we think about systemic sclerosis, but we think about other differentials as well. Keep in mind, because it will help you in later when the examiner asks you questions. So you must have all the differential diagnosis in your mind. Localized scleroderma or morphia, well, this condition primarily affects the skin and underlying tissue, and it does not involve internal organs. And usually there is a localized area of skin hardening and discoloration. So not applicable to this patient. Rheumatoid arthritis, well, is another autoimmune disease, can affect the joint and skin. But skin changes in rheumatoid arthritis, we normally see rheumatoid nodules, and these can sometimes mimic involved in systemic sclerosis. Another differential to consider is lupus. Systemic lupus erythematosus is another autoimmune disease, and it can have skin manifestations. Particularly, we see the butterfly rash on the face. But systemic sclerosis, they have distinct skin changes that are usually more extensive, and they are associated with mask-like appearance like tight skin, tight and shiny skin. Mixed connective tissue disease, well, it shares some features with systemic sclerosis, but it is distinct identity and include a combination of symptoms from SLE, systemic sclerosis, and polymyositis. Polymyositis and dermatomyositis, well, we know these are inflammatory muscle disease that can have skin involvement, including a rash. However, the characteristic skin changes seen in systemic sclerosis is not a feature of this condition. Sarcoidosis, where it is characterized by formation of granulomas in various organs, including the skin. So skin lesion in sarcoidosis can sometimes be confused with systemic sclerosis. But normally in the sarcoidosis, you remember there's a specific rash called lupus perineo, and it is mostly involving the nose actually. Sjogren's syndrome is another autoimmune disease, characterized by dry eyes and mouth. It can co-occur with systemic sclerosis. It can also present with dryness and skin changes, which might overlap with systemic sclerosis. Dermatomyositis, we already have discussed. It is an inflammatory muscle disease, skin involvement, but skin manifestation can sometimes resemble, but muscle weakness is a hallmark feature of dermatomyositis. Normally we have a proximal muscle weakness, and as you can recall, for dermatomyositis there's a specific rash called heliotrope rash, which is around the eye, periorbital region, and there are Gottron papules, which are specific rashes which can present on the hands and the knuckles. So these are quite distinctive actually. Eosinophilic fasciitis, whereas it involves the thickening and inflammation of the fascia and can present with skin changes and pain, can sometimes be confused with early changes of systemic sclerosis. And finally, paraneoplastic syndrome. In some cases, symptoms similar to systemic sclerosis can be associated with underlying malignancies known as paraneoplastic syndrome. So I put a lot of differential diagnosis here, but if you can manage to remember 4 or 5 or even 3 should be enough. Okay, let's move on. How we're going to investigate this patient. Now I put this the information here because this you may come across this in your Viva questions. So we're going to do autoantibody testing. We're interested in ANA. Almost all these systemic sclerosis patients have positive ANA test. And then we have specific autoantibodies, testing for specific systemic sclerosis related autoantibodies such as anti-centromere antibodies and anti-SCL70 or anti-topoisomerase 1. Then other antibodies include anti-RNA polymerase 3 and anti-U1RNP antibodies, and these all can help subtype and predict the disease manifestation. Measurement of skin involvement changes use tools like modified Rodnan skin score. You're not going to do it, but just mention it that so the examiner know that how you will assess the skin involvement. Nail fold capillaroscopy, well, examination of nail fold capillaries under a microscope to assess for specific patterns and abnormalities associated with systemic sclerosis. Pulmonary function tests, spirometry and diffusion capacity testing to assess the lung function and identify the restrictive lung disease in this case. High resolution CT scan to evaluate the lung involvement, identify interstitial lung disease and assess the extent of fibrosis. We'll be interested in the echo to assess the cardiac function, pulmonary artery pressure and detect signs of pulmonary hypertension. Esophageal manometry to evaluate the esophageal dysfunction. We assess for the GERD and identify the swallowing difficulties. Upper GI endoscopy to visualize the esophagus and stomach and to assess for erosion structures and Barrett's esophagus. ECG and echo I already mentioned. Then serum biomarkers like measurement of the serum markers like CK and ESR and CRP to assess for inflammation and muscle involvement. We're going to check the urine as well to check for kidney involvement, detect any urinary abnormalities, CBCs mainly to monitor for anemia, leukopenia and thrombocytopenia. Imaging studies are important like MRI or ultrasonography to assess the skeletal, musculoskeletal involvement, especially in case of joint pain. Endothelial function testing to evaluate the endothelial function. Biomarkers of fibrosis, major biomarkers like pro-collagen type 1 and 3, which can indicate the degree of fibrosis and monitor the disease progression. And finally, biopsy. In some cases, skin or lung biopsy may be performed to confirm the diagnosis and assess the degree of tissue damage. So try to remember as many investigations as you can. I have put almost everything here. What about the management? How are we going to manage the patient? So early diagnosis and monitoring is important. Regular follow-up with a rheumatologist or a specialist experienced in systemic sclerosis is essential to monitor the disease progression and initiate the timely intervention. Immunosuppressants play a key role in the management of systemic sclerosis. So mycophenolate mofetil, it is often reduced to reduce the inflammation and fibrosis, and particularly effective in patients with skin and lung involvement, and it's available in oral and IV forms. Another immunosuppressant which can be used is methotrexate, and especially in patients with skin involvement, and can help control skin thickening and inflammation. Another immunosuppressant is cyclophosphamide, and however this is reserved for severe and rapidly progressive systemic sclerosis, especially in cases with severe interstitial lung disease, and is often administered IV. So immunosuppressant is one group. Then we have another group called vasodilators like calcium channel blockers, nifedipine, and these commonly used to manage Raynaud's phenomena in systemic sclerosis because they help to relax and dilate the blood vessels, improving the blood flow to fingers and toes. Gastrointestinal medication like PPI, they can help reduce stomach acid production, and then motility agents like metoclopramide or erythromycin may be used to improve esophageal motility and alleviate the swallowing difficulties. If the patient has complications like pulmonary hypertension, then we have endothelial receptor antagonists. These can help reduce the narrowing of blood vessels in the lungs. Phosphodiesterase 5 inhibitors like sildenafil. This works by relaxing the blood vessels in the lungs, improving the blood flow and reducing the pulmonary hypertension, and prostacyclin analogs. And these are potent vasodilators used for severe pulmonary hypertension. Then pain management, we can give some analgesic for patient experiencing joint pain or digital ulcer. Non-prescription pain relievers like acetaminophen or NSAID may be used. Biologics, some biologics such as rituximab and tocilizumab, these are being explored for treatment of systemic sclerosis, particularly in cases with significant skin and lung involvement. Patients are also advised to avoid the cold exposure as it can trigger Raynaud's phenomena. If the patient is a smoker, we ask them to quit smoking. Physical and occupational therapy can help manage joint stiffness and improve function. Dietary changes, patients with swallowing difficulties or acid reflux are often advised to modify their diet and eat smaller, more frequent meals. Pulmonary rehabilitation, patient who got lung involvement may benefit for pulmonary rehabilitation program. Raynaud's phenomena management, well, keeping the fingers and toes warm with gloves and heated hand warmers is advised, and calcium channel blockers or other vasodilators may be prescribed for severe Raynaud's phenomena. Digital ulcer care, specialized wound care and medication may be necessary. Organ-specific management like GI, renal crisis or heart complication, they require targeted management by respective specialties, and patients do need some psychological support because living with chronic conditions can be emotionally challenging, so patients benefit from psychosocial support, counseling and access to support groups. Patient education, patients should be educated about their conditions, symptoms and importance of regular follow-up. And surgical intervention is needed in some cases, such as amputation for severe digital ulcers or lung transplantation for advanced lung cancer. In certain cases, particular participation in clinical trials may be considered. All these patients need regular monitoring. So, systemic sclerosis patients, they require regular monitoring, including clinical assessment, laboratory tests, imaging studies, and pulmonary function tests to track the disease progression and treatment response. So remember that I put so many things here. Try to divide them in groups. So there are some medications. One group is immunosuppressant, vasodilators, gastrointestinal medication, pulmonary hypertension management medications, and then we have some education and then support, psychological support, patient education, and regular monitoring. So management of systemic sclerosis, remember, is highly individualized, and the care team will tailor the approach to the patient's specific symptoms and needs. So collaborative, multidisciplinary approach is essential for providing comprehensive care to systemic sclerosis patients and improving their quality of life. So this is all about the investigations. Hopefully I have covered everything. So let's move on, and how are you going to present the case to the examiner? So again, I've divided into different sections. Try to remember these sections so you don't miss anything. So you're going to start by introduction. Good morning. I would like to present the case of 48-year-old female patient who presented to a clinic with multiple symptoms and concerns related to her health. The patient, and then going to start with the presenting complaint. The patient primary concern is a progressive skin thickening, particularly in her hands and face, which she has noticed over the past 2 years. She also experienced Raynaud's phenomena with color changes in her fingers when exposed to cold temperature. Then you will move on, and then going to give some details about the history of present illness. The patient's symptoms began 2 years ago with skin changes involving her hands, which gradually extended to her face. She described the skin as becoming thicker and tighter. She has also noted the appearance of dilated blood vessels on her face. Over the same period, she has experienced episodes of Raynaud's phenomena in her fingers with a bluish discoloration and associated numbness. Then we're going to talk about the other systems. The patient denies any significant joint pain or swelling. She reports mild acid reflux and intermittent difficulty swallowing. She occasionally experienced dry cough and mild exertional dyspnea. She denies any abdominal pain or changes in bowel habits. Important negatives which you should mention in your history. Past medical history, the patient has no significant past medical history, autoimmune disease or chronic illness. Patient is not currently taking any medication and she reports no known drug allergies. The patient is a non-smoker and consumes alcohol socially. She works as a school teacher and reports no recent travel or significant environmental exposure. There is no family history of autoimmune disease, already mentioned. Um, then you're going to, you have talked a bit about the history. You can shorten it as well. Then we're going to talk about the physical examination findings. On examination, I observed significant skin changes with thickening and tightening, mainly involving the fingers and face. There is evidence of telangiectasia on her face. Nail fold capillaroscopy revealed a scleroderma pattern, and you can skip it. Pulmonary examination was unremarkable. Cardiovascular examination showed no signs of pericardial effusion or abnormal heart sound. Musculoskeletal examination showed joint contractures in her fingers, and there was no evidence of finger clubbing. So in some scenarios, when you ask about some investigation, the patient may give you some details about the investigation done. If it is done, is okay. Otherwise, you're going to just suggest the investigations. So laboratory studies, including a positive ANA test, the patient also tested positive for anti-centromere antibodies. If the patient has given you the results, high resolution CT of the chest show evidence of interstitial lung disease. Echocardiography indicated no signs of pulmonary hypertension. So if the patient has given you all this information is okay. If not, then you're going to suggest that in order to confirm my diagnosis, I like to do some blood tests, including the ANS test, anti-centromere antibodies. I like to proceed with a high-resolution CT scan and echocardiography to look for any evidence of pulmonary hypertension. Then you're going to talk about the diagnosis and differential diagnosis. So based on the clinical presentation, positive autoantibodies imaging studies, the working diagnosis systemic sclerosis. Differentials include localized scleroderma and mixed connective tissue disease. And then finally going to talk about the patient treatment and management. So patient will be referred to a rheumatologist for further evaluation management. Treatment may involve immunosuppressive medications, vasodilators for Raynaud's, and proton pump inhibitors for acid reflux. Regular follow-up and monitoring of organ involvement will be emphasized. The patient will be scheduled for follow-up with rheumatologist to assess disease progression, monitor lung function, and provides organic care. So I put a lot here, but you can modify it and shorten it. The idea is to give you all the headings so you don't miss anything. And then you're going to conclude. In summary, this case represents a 48-year-old female patient with a working diagnosis of systemic sclerosis, presenting with skin changes, Raynaud's phenomena, and specific autoantibodies. A comprehensive evaluation and multidisciplinary care essential for her management. So again, I have emphasized here, when presenting a case, it's crucial to maintain a clear and organized structure and address any questions or requests for additional information from the examiner. So this is about the presentation. Then there are some questions which could be asked by the examiner. I have put few here along with the answer. So examiner may ask, what are the main clinical features of systemic sclerosis? So the main clinical features of systemic sclerosis include skin thickening and tightening, Raynaud's phenomena, digital ulcers, telangiectasias, joint pain and contractures, GI symptoms, dysphagia, reflux, abdominal pain, lung involvement, interstitial lung disease, pulmonary hypertension, and various autoantibodies. Can you explain the role of autoantibodies in the diagnosis and classification of systemic sclerosis? So autoantibodies, these are actually crucial in diagnosing and classifying systemic sclerosis. Common autoantibodies which are associated with systemic sclerosis, they include, I already explained to you before also, anti-centromere antibodies, anti-SCL70 or anti-topoisomerase 1 and anti-RNA polymerase 3 antibodies. So these autoantibodies help subtype systemic sclerosis and predict disease manifestations. Like anti-centromere antibodies, these are all usually associated with limited cutaneous systemic sclerosis, while anti-SCL70 antibodies are linked to diffuse cutaneous systemic sclerosis. Sorry. Examiner may ask, what diagnostic criteria are used to confirm the diagnosis of systemic sclerosis? So here is the answer. The American College of Rheumatology or European League Against Rheumatism criteria, these are commonly used to diagnose systemic sclerosis, and these criteria consider skin changes, autoantibodies, nail fold capillaroscopy, and internal organ involvement. So presence of specific autoantibodies in combination with typical clinical findings, these can support the diagnosis. What is the management approach for Raynaud's phenomena in a patient with systemic sclerosis? Well, the management in a systemic sclerosis include lifestyle modifications, avoiding cold exposure, smoking cessation, pharmacological interventions like calcium channel blockers, and keeping fingers warm with gloves or heated hand warmers. Again, there is a repetition, but these are the common questions which are asked in this case. How do you monitor and manage pulmonary involvement in systemic sclerosis? So, pulmonary involvement such as interstitial lung disease and pulmonary hypertension is monitored through high resolution CT scan, pulmonary function test, and echocardiography. Management may involve immunosuppressive medications, oxygen therapy, and in the case of pulmonary hypertension, vasodilators. So, keep your answers simple because they already tested your knowledge in Mrcp in written examination. So here you just have to show the confidence, and the examiner just give the examiner an idea that you know your topic and you know how to proceed. What are the potential complications and prognosis associated with systemic sclerosis? So potential complications include pulmonary fibrosis, pulmonary arterial hypertension, renal crisis, and severe digital ulcers. And the prognosis varies depending on the extent and severity of organ involvement. So early diagnosis and multidisciplinary care can significantly improve the outcome. And what is the role of multidisciplinary approach in the management? Well, multidisciplinary approach is vital in systemic sclerosis management. We need rheumatologists, pulmonologists, cardiologists, and other specialists. They collaborate to address the various aspects of the disease, provide comprehensive care, and manage organ-specific complications effectively. And finally, how would you educate the patient about systemic sclerosis management? So here again, I put emphasis on my management. Again, I'm going to talk about patient education. So it is crucial in systemic sclerosis management. So I will explain the nature of the disease, the importance of early diagnosis, the significance of regular follow-up, and the potential complications. I will provide information on lifestyle modification, the importance of smoking cessation, and the need for prompt reporting of new symptoms. So this is all about the systemic sclerosis. If you come across this case in your consultation station, hopefully it will help you, and I will see you again in my next presentation. Thanks a lot, and take care of yourself.